and I work harm reduction at the West Java province, supported by NCPI Coast and James Block is my co-author for this presentation. Okay, Indonesian government very supported for methadone clinic. So at least there is 3 policy. Number 1 is from Ministry of Health decisions, and then Narcotics Law number 35, 2009. This narcotic law is a new law in Indonesia after the government has revised from previous narcotic laws, and then the Ministry of Social Welfare decisions. All right. On the harm reduction program, based on World Health Organization, there is only 4 components directly can prevent injecting drug user from ICAAPX. So one of them is methadone. Indonesia has developed the methadone clinic on the 2005. Indonesia has developed in the 9 provinces. There is West Java, DKI, and then Jogja, East Java, Tangerang, and others. And then the methadone clinic there is in the hospital and community health services. The program methadone clinic are supported by USAID and other international agencies like Global Funds and others. Here is the mechanism of methadone services. So there is 3 important components: province hospital as main services, and then NGO, and then community health services. The 3 component has own job. For example, main service in the provinces hospital, they do technical assistance to the satellite at the community health center, and then they do the methadone meeting for the client and family too, and then they do some kind of refresh training for the staff of clinical methadone. And NGO, they are conducting some kind of meeting with the client, family, and then referral the injecting drug user to the methadone clinic, doing some assessment, and they do the counseling too, to make the services is more better. Also for the case management and others. But Indonesia in methadone clinic there is a problem with the huge estimated people with injecting drugs. The people with injecting drugs is usually don't like services in the clinic. But the clinic often don't like people with injecting drugs too. So it's a problem. Many reasons why people with injecting drugs don't like service in clinic. For example, the clinical service usually use the uniform. There should be a reason, one of the reasons. And then There is too many bureaucracy, how to register, how to wait, and others. Is very unique character from the injection drug user. So that's why there is many low adherence, high dropout, and low success rate. So, and then we try to make some system to integrated care in the services, in the clinic services with the methadone. And then patient-friendly convenience, and then establish doctor, patient relation, and then comprehensive service, and of course, cost-effective approach. Here is the scale of methadone integration. You can see that if the NGO can conducting the outreach more higher outreach with the information, education, and a referral to the clinical services, it should be more higher in the health services access, in the public health service or community health service, or maybe at the hospital too. It should be the same numbers. Okay, let's see the surveys, because every year HCPI also a partner in the NGO and then community health service conducting the surveys. In the 2011, all the partners of HCPI also conducting the surveys. All the responding who attending harm reduction service during 3 weeks had opportunities to complete the questionnaire. And then the questionnaire is about people with injecting behavior, including whether they are injecting while on substitution therapy. Here is the result. I tried to compare between 2010 and 2011. Little bit change about respondent in 2010 and 2011. There is 52% receive OSD and 80% currently receiving OSD and 70% methadone. More in DKI and CNC participant in 2011. And then you can see that more long the client using methadone, and then more lower injecting between them. Even the number is very fluctuating, but more loners following the methadone, more low the number injecting the drugs. So this is the presentation. The percentage injecting low. There's many reasons why they are still injecting. One the reason is they are low dose, make them still injecting. This is the rotation of IRT. With IRT, patient in IRT is many good retention, but this is I took from the province hospital. Okay. This is my conclusion. There was a progressive decrease in injecting by dose using methadone during 2 years treatment. low dose is one issue that can be addressed by service provider. Maintaining engagement with participants require implementation of quality program, passion of MMT, and better orientation on IRT. Addiction is chronic disorder, but methadone provides stability to address other issues, social problems, mental health problems, HIV, and other medical problems. Thank you very much.